The American College of Radiology.
Focused. Forward.
Together.
Okay, I think we can get started here. Good evening and good afternoon and even good morning, depending on where you're located. Welcome to the second edition of our educational series on Alzheimer's disease and dementia. I'm John Jordan, chair of the ACR Commission on Neuroradiology and moderator for this session. And my co-moderators are Dr. Christopher Whitlow and Dr. Jerome Barakos. Dr. Barakos is the Director of Neuroimaging at the California Pacific Medical Center and Sutter Health, and Dr. Christopher Whitlow is Professor and Chair of the Department of Radiology at Wake Forest Medical Center. This session is sponsored by the ACR Commission on Neuroradiology and the Commission's Dementia Work Group, and co-sponsored by Icometrics and Eisai Corporations, and offered in partnership with ALSNet, the Alzheimer's National Registry for Treatment and Diagnosis. All of the speakers and moderators today are members of the ALSNet Imaging Committee. You can learn more about ALSNet at alsnet.org. Today's session will be an exciting and informative program, and we thank all of you for your attendance. The session is entitled Amyloid-Related Imaging Abnormalities, a Case-Based Approach. Your faculty for today's webinar are leading experts in the field, including Dr. Tammy Benzinga, Dr. Greg Hartsock, and Dr. Anna Francesca. We are so fortunate to have such an outstanding panel. Before we get started, a few announcements are in order. 1.5 hours of CME credit will be available for this webinar. The webinar is being recorded and will be available online as an enduring activity for those who may have missed this session or would like to view the course again. For more information, you may contact info@acr.org. If you would like to direct a question to the faculty, you may do so by entering a question in the Q&A panel. You can also use the chat function to communicate with fellow attendees during the session. You can minimize the chat box if you do not want to see the chat messages. Please do not place your questions, however, in the chat function. Please note that you can find out more about additional educational opportunities for neuroradiology and other radiologic specialties through the acr.org website under the Lifelong Learning and CME tab. There you can also find information about upcoming ACR courses, including how to register for them and gain additional educational and clinical training. Finally, if you have any questions about the course, please email us at info@acr.org. Now, without further ado, I would like to introduce our first speaker, who is Dr. Tammy Benzinga. Dr. Benzinga is a professor of radiology and neurological surgery and medical director of MRI services at Washington University School of Medicine in St. Louis. Tammy will provide an introduction and background regarding ARIA and review some clinical cases of ARIA. Without further ado, Tammy, please, and welcome to the virtual podium.
Thank you so much. I'm really excited to be here with all of you and to move forward in sharing some information on ARIA and initial experiences with it. So I'm going to share my screen. And just, as Dr. Jordan mentioned, this is co-sponsored with the ALSNet or Alzheimer's Network, and I stuck a QR code for that here, and I put it in a couple of other places as well because their website links together resources from the ACR and from other organizations, and it's just a really great place for radiologists and radiology technologists to go and find consolidated information. So I encourage you to take a look at that information, a lot of which we are presenting here tonight. These are my disclosures. I'm primarily funded by the NIH, but we do have involvement. I have involvement in a number of clinical trials, and I also do consulting related to Alzheimer's disease. Of course, we're all here talking about Alzheimer's disease and the way that it has been silently increasing in the United States. And as radiologists, we get a lot of questions from our families and patients about the new drugs, the new medicines. As neuroradiologists, we get a lot of questions from others in our groups about how this might impact our practice. And of course, there's also the downside, so the side effects. And that, of course, is ARIA. And how can we as radiologists play a role in helping prevent patients from having severe consequences related to that? So just to set the stage, there have been a few cases reported, and this is an example of one from the literature last year of a patient presenting. She was 79 years old and presented with seizures, was taking anti-amyloid immunotherapies. And what you can see on these images on the baseline flare compared to during treatment, when she starts to come in with seizures, are these multifocal areas of white matter, hyperintensity increasing, and in particular, the swelling. So effacement of the sulci, sulcal effusions, and then the hemorrhages. So microhemorrhages in the parenchyma, as well as superficial siderosis. And an autopsy, so there are not very many autopsy cases for us to rely upon, but this particular case had lymphocytic infiltrates, reactive macrophages, some deposits of amyloid in blood vessels, particularly meningeal, and numerous microaneurysms. So this is what we're watching for with all of the surveillance MRIs, and this is what we want to catch early to prevent it from becoming a fulminant case. So, as was stated, we're going to be bringing you cases from all over the US of ARIA and are sharing our experiences in our different practices, including not just what to look for on the scans, but also what to think about in terms of your clinical workflow, your MRI protocols, how to make this feasible and efficient. So I think to understand ARIA, one of the most important things to understand is cerebral amyloid angiopathy. So I wanted to start with this. And this is just this idea that with CAA and with Alzheimer's disease, you have amyloid deposits not only in the brain parenchyma, but also in the blood vessel walls. And in fact, this will impair the blood vessels, and it can result in leaking. And so this could be in the form of edema, can be in the form of hemorrhage, and can also set off immune responses, even in the absence of therapy. And this is just an example for you. This is a 76-year-old patient at our hospital a few years ago, so prior to these therapies. She came in with a chronic memory loss, but superimposed acute confusion. And if you look, you can see throughout the left temporal lobe and a little bit in the right temporal lobe, this vasogenic edema with effacement of the sulci, a few areas where you can see some sulcal effusions even. If you look carefully on our blood sensitive sequence, a T2 star, you can see numerous microhemorrhages, and notably with a lack of findings on contrast enhancement and no restricted diffusion to suggest an infarct. And so this was a case of CAA. And what you can see is when she comes back for follow-up, we have resolution of the findings on flare, but persistence and even additional accumulation of microhemorrhages that can come up. And you can assess for these using a gradient echo T2 star or using SWI. Or SWAN, which is a little bit more sensitive in 3D sequence, but not available on all scanners. And what you'll see in the slides I present is at our institution, we will run both of these side by side to give us the best advantage for comparison across scanners and vendors. So I wanted to move on to talk about what are these immunotherapies and what is ARIA, or the amyloid-related imaging abnormality that we see during the course of therapy. So a whole set of monoclonal antibody therapies have been under development and testing in recent years, which are all focused on these aggregates of beta amyloid. And with these monoclonal antibodies, they will attack the aggregates, and then the immune system itself, the microglia, will then attach to those antibodies and clear this from the brain. And what you see with PET scans in these patients is very dramatic clearance. So here's a patient who is on aducanumab, and you can see that on placebo, there's no change on amyloid PET, but that clearance of the plaque on amyloid PET during the therapy. And so, again, there have been just a great number of trials that have been published. The first one that had an approval in the US was aducanumab in 2021, and that was followed by lecanemab in 2023. Lecanemab is currently approved by the FDA in the US and also reimbursed by CMS. And aducanumab has been removed from the market by Biogen. So for now, the main therapy that we're talking about is lecanemab, but there are just a number of these that have been in the pipeline and are coming out in the future, as well as drugs focusing on tau targets. And so that'll be something we'll talk about hopefully in future webinars as those become approved. So ARIA was first described for bevacizumab, and it is usually asymptomatic, but if it does have symptoms, they're usually very vague: headache, confusion, visual changes. And because of this, these US FDA labels recommend baseline and serial MRI monitoring to look for these radiographic findings. And it's so important for us to understand that detecting ARIA, even small areas of change on flare, will change the management because it can result in more frequent imaging, held doses, or potentially even other therapies such as steroids or hospital admission. So what does it look like? Very similar to that CAA case, right? You've got vasogenic edema, sulcal effusion, so that's ARIA-E, and then you'll have microhemorrhages and siderosis, and those make up ARIA-H. Risk factors for ARIA, most importantly, is the ApoE4 genotype, so that's recommended for these patients to undergo genotyping as a way to assess risk. It's not a contraindication for the therapy, but it's a relative contraindication and definitely something that families need to know about and talk about. The other important thing is that if patients already have multiple microhemorrhages, that may be a sign that they have a high load of vascular amyloid to begin with, and that's also a risk factor for future ARIA. And then finally, most of the clinical trials did exclude other major brain pathology, such as infarct, which could also have a risk of bleeding. So those are all things you want to look at on that baseline MRI and report. Just wanted to show you, this is one patient who was in one of our clinical trials in the Diane TU, and you can see the changes in flare over time as this patient developed ARIA-E in the bilateral occipital lobes and in the right temporal lobe. And that was followed by ARIA-H, starting to develop these microhemorrhages in those same areas on the right. Now, this was a patient in a trial, so we do have serial amyloid PET imaging to look at as well. And if we do a subtraction imaging for amyloid PET, you could see those same areas that developed ARIA were having the highest clearance on their amyloid PET, which is very interesting. So for clinical work, we recommend a consistent imaging protocol because you all know these microhemorrhages are so hard to follow if you have different techniques each time. Also, you need to be thinking about how many MRIs they need. So commonly getting 4 to 6 over the course of 12 months. The patients get infusions every 2 weeks. And so the MRIs need a fast turnaround time to give a result before that next infusion. Usually they'll schedule them for an MRI the day before the infusion. And then they do add-on requests for these symptoms: confusion, headache, dizziness. And so you have to be prepared for how will we work these patients in the schedule and get this happening. So just to share our experience, we've been infusing lecanemab for about 9 months now, and we have 176 patients on therapy. And we use unique orderables for the monitoring exams to help drive our workflows in terms of the protocol on the scanner as well as the dictation template. And with that, we can actually track these volumes. And so we have actually generated over 1,000 MRI visits related to this therapy program. And so it's really required a strong commitment, not just at our university hospital, but at every hospital in our network, including radiology groups that aren't part of our academic center. And it's demonstrated a remarkable shared commitment to patient access to help make these exams available, and a shared commitment to the standardization of protocols and reporting have made this very seamless. This is just a schematic of those MRI visits to kind of help you understand it. So they're going to need the baseline MRI within a year prior to initiation. Frankly, I usually encourage them, if it's more than a few months old, or especially if it's from an outside network, to please get a repeat in our system with the standard protocol. And then they get, these are their infusion schedules with the T letters, but they're going to get an MRI before infusion 5 and 7 and 14, but they'll also get additional MRIs anytime they have symptoms. So a lot of other patients getting these baselines who then don't come into therapy, and that's how we get to 1,000 MRIs very quickly. So for that, again, for the baseline MRI, make sure to report any hemorrhages greater than 10 millimeters, count the microhemorrhages, look for siderosis and vasogenic edema, and as well as anything that could increase risk of hemorrhage, such as aneurysm, stroke, AVM. And again, here's that link to those ALZnet resources, which are going to be so helpful for consolidating ideas about protocols and templates and so on. So again, the symptoms of ARIA are very similar to other things in an elderly population. So you have to have a very open mind when these patients present to the ER or to your outpatient clinic, to be thinking about the fact they may be on this therapy if they're in this age group or have a history of memory loss. So the ARIA grading system, you're going to see a lot of cases tonight that are going to go through this grading system in detail, but I think we'll repeat it for you. I think it's hard to remember. We've built it into the templates at our institution. We recommend that to make it easy for the radiologist, but basically mild is if it's just one lesion less than 5 centimeters. Moderate would be more than one lesion and in the 5 to 10 range, and severe would be greater than 10 centimeters. So pretty huge to be severe. ARIA H, this is where it's tricky, right? 4 microhemorrhages is mild, 5 becomes moderate. So counting those microhemorrhages is really hard. And then the siderosis, once you have more than 2 areas of siderosis, you're all the way to severe. So here's a case, 72-year-old here for ARIA monitoring. You can see that there's a flare hyperintensity and associated microhemorrhage without diffusion restriction. So this would be a great example of ARIA, obviously. And we're going to call this mild because we have just one area, but it's going to be E and H because we have both of those findings. And I recommend putting these just on separate lines in your impression to make it easier for the neurologist. Here's another case. She comes in. These are new findings of bilateral occipital flare. You can see edema as well as sulcal effusion. You can also see microhemorrhages and siderosis, no restricted diffusion. So again, another example of ARIA. And here for the severity, it's still just moderate. And so that's really important to remember. Moderate is this pretty broad category. These are less than 10 centimeters, more than one area. So that makes it moderate on ARIA E. Microhemorrhages were still less than 10, and the siderosis is still less than 2, or 2 areas rather. Here's another patient, asymptomatic, coming in. And what I want to show you is what we have is one microhemorrhage. In this case, you can see it better on the SWI than on the T2 star. But as I mentioned, we're running both of these for comparison. So with one microhemorrhage that was asymptomatic, the decision was made to continue the dosing. Now, 1 month later, before infusion 7, still asymptomatic, but now you can see an area of flare hyperintensity, 1.8 centimeters, as well as an area of siderosis that's showing up. So there's also a microhemorrhage I'm not showing you. So now we've got mild ARIA E. There were 2 areas of siderosis that made it moderate, and 1 area of microhemorrhage, so mild for that. So each of these is an impression line, and with all of that, they decided to put the dose on hold and transfer this patient in for more centralized care. So I just wanted to show you some challenges that we had with this case, and that is that the baseline had this coronal gradient echo from an outside hospital, made it really hard to determine whether the microhemorrhages were new or old. This was one of the advantages of including the SWI, and that we could reformat it to identify which lesions were new versus old. This is another case, an 82-year-old woman who was having some memory complaints. Now, interestingly, this patient had a history of a prior stroke. So it was in 2022, she had left arm ataxia. So this is just showing you when that infarct had some edema with it. And now in 2023, it's more chronic. And then here are her scans, pre-treatment baseline, pre-infusion 5. And so what happened to this patient pre-infusion 5 was she developed this cerebellar area that on FLAIR looks hyperintense, but in fact has restricted diffusion. So this was actually a cerebellar infarct, not ARIA, and was just really important. That's why we include diffusion in the sequence, even though what we are categorizing for ARIA is FLAIR and the T2 star or SWI. So these patients can have any of the other things like infarcts that can happen. It's really important that you know they're on therapy and that they go down the right course of treatment. Okay, I'm going to try to show you a couple more very quickly. This is case 5. This was a patient with early onset Alzheimer's disease, only 57 years old, but she had an 18-month history of memory complaints and was forgetting events with her close friends. She had her testing and had a lumbar puncture that was positive. This is just showing you the progressive brain atrophy you could start to see even on a head CT. And then this is showing you a baseline microhemorrhage that she has across all the visits. But then she develops a new microhemorrhage in the right frontal lobe, pre-infusion 7, that stays there. She ended up having her infusions held for nausea and vomiting, which can be a symptom of ARIA, but in this case was deemed to be unrelated. She then, even though the infusions were on hold, developed yet another new microhemorrhage in the left temporal lobe. And this is common that these microhemorrhages can accumulate even off therapy, and it's unclear, perhaps again, this is potentially an underlying CAA type picture. And so she did go back to being on therapy once the nausea and vomiting had resolved and is doing well. Okay, last case is a 77-year-old. She was also coming in for some asymptomatic monitoring. And what you can see here, pre-infusion 5 on FLAIR, bilateral frontal lobe edema without diffusion restriction, but does have associated with it a microhemorrhage. And in fact, those FLAIR hyperintensities also involve multifocal areas in the brain. And there were additional microhemorrhages. And so she actually had a case of moderate ARIA E, mild ARIA H, and that resulted in a hold on the infusions. I'm going to try to scroll this for you, just so you can start to get a sense of the widespread areas of the vasogenic edema, as well as the multifocal microhemorrhages. And, incredible to think about finding this dramatic still being asymptomatic. And you can see how subtle those microhemorrhages are, but you can see them kind of pop in and out as they go by. Okay. So just to summarize for that one, I wanted to put in an example of a report and how do you report it. So it's really helpful to talk about any prior. So the prior exams demonstrates no microhemorrhages. Any new microhemorrhages, so on this at this particular time point, 2 new microhemorrhages, say where they are, and then the total is 2. And then when you come down, you can put that in as a separate impression line. And this is just showing you then how that resolves. So you can see that edema goes away over time. Microhemorrhages. So unfortunately, she developed even more microhemorrhages a month after that. And I'll just cut to the chase here. So she eventually had, so baseline, moderate ARIA-E, mild H. Then she still has moderate E, but moves to severe ARIA-H because she had 10 microhemorrhages. 2 months later, the ARIA-E has resolved, but you can see for her, the outcome was therapy was discontinued permanently, and this was because of that severe ARIA-H. And, you know, I really think that because of that careful analysis and counting and monitoring, we may have prevented a more serious complication. And so, again, just really highlights the role that radiology has in these patients. And so with that, again, here's the link to those ALZNet resources. Just want to remind you that treatment can accelerate microhemorrhages and vasogenic edema, and this is what we call ARIA. It does overlap with what you think about for CAA, which is good news. We know how to diagnose CAA. If you standardize your orders and protocols and reporting, that can help a lot. And you should think about how you're going to handle this increased capacity, potentially, not just for MRI, but also for lumbar punctures and amyloid PETs, depending on your practice setting. And so with that, I'll thank you for your attention and thank all of our research participants over the years for their assistance.
Wow, thank you, Tammy. That really was fantastic. So that was a beautiful overview of the topic. And what should be evident to our audience as radiologists is this truly is an exciting time in the field of Alzheimer's disease, as there's really a palpable sense that with these new anti-amyloid agents, we may be able to slow the mental decline associated with Alzheimer's. But most importantly, this also clearly places the spotlight on the radiologist, because the results of every MRI we read will dictate and influence whether a patient receives their next dose of drug, or if they're even eligible for treatment with these anti-amyloid therapies in the first place. So with that, our next speaker will be Dr. Greg Hartsock, who will take a deeper dive into the topic of ARIA with more case examples. Now, Dr. Hartsock is professor of radiology at the Stanford School of Medicine and Medical Center in the Division of Neuroimaging, and really an honor to have Greg with us here as well.
Thank you so much. Can you hear me? I'm assuming
Yes.
that's a yes.
Yes, we can hear you. We can hear you.
So that was a fantastic introduction, and I'm going to be covering some of the similar ground to Tammy. Again, more focused on a little bit more of the history of how we got to where we are today. So let's dive right in. Let's dive right in theory. Okay, there we go. So here are my disclosures. I think the most relevant is that I have been involved with Biogen on advisory panels, but I don't have many cases that I'm showing from Biogen as part of this presentation. Okay, so I have to click. So, you know, first, just to take a step back, I mean, we've been talking about Alzheimer's disease, but it's really important to realize that dementia is an umbrella term for many different underlying pathologies. And while Alzheimer's is the most common, it's important to remember that there are other entities that can present. So again, this is one of the key reasons that neurology has to be very careful, because, you know, it is not thought that these drugs would affect any of the diseases listed here, except Alzheimer's. And sometimes it can be very difficult to really decide what the actual pathology is. So just again, I think this speaks to the importance of really close examination of the patients and really identifying the right patients for these new medicines, which are quite exciting. Okay, so we talked a little bit about the role of amyloid, and just to kind of lay the playing field, what we see in these patients, if we go to autopsy, can be these extracellular neuritic amyloid plaques, which we can image, and we'll talk about that. And then another hallmark of the disease is neurofibrillary tau tangles. And I want to just bring this up a little bit to start, because I will be talking about some of the newer agents which may require us to also image tau. Okay, so let's start with amyloid imaging, just so everyone's on the same page. This is a radio tracer that binds to insoluble beta amyloid. There are 3 vendors currently that make a version of this. And one of the interesting things about it is that you can actually have a positive scan and still be cognitively intact. So the presence of beta amyloid in the cortex, which defines the difference between a positive and a negative scan, so a positive scan here on the left, a negative scan here on the right, is really determined by whether the tracer is being taken up within the cortex itself. And so you may be asked to read these. There are a lot of resources online to help you with how to do this. I think one of the most interesting things about amyloid imaging, of course, is that a negative study excludes AD. So that I think is very helpful. So patients need to have positive amyloid imaging or a positive lumbar puncture to really be considered for these drugs. And then the last thing that I think is really fascinating and important is that amyloid tends to build up during a preclinical period. And that is very intriguing, because it is raising the question of whether perhaps patients can be treated with these drugs before they develop symptoms. And there are currently ongoing trials looking at this. Okay, in terms of tau imaging, I may be a little bit less familiar to most of us because we don't do very much of this. But the goal is here to image actually these neurofibrillary tangles, which are thought to be a downstream effect. This has been used in the setting of Alzheimer's disease as well as chronic traumatic encephalopathy. There are multiple agents that are available to be used. And I think the key point is that this tends really to increase after the presence of amyloid deposition. So again, could be considered another excellent biomarker for this disease. And one of the reasons that it is useful is that it seems to have better correlation with current clinical symptoms. So obviously, one of the big challenges in Alzheimer's disease research is objective assessment of cognitive impairment. And this can be quite subjective. So the thought that we could have an imaging technique that could use this, could do this, would be very helpful potentially. Okay, finally, I'm not going to talk too much about MR findings in AD, because probably the most common MR finding in AD is no change, is a normal looking study. There are characteristic atrophy patterns, as I've shown here in the biparietal areas and the precuneus. Often the atrophy is a late finding. So by the time you see this, usually there's no question about a diagnosis. There is some quantitative software, both freeware called FreeSurfer and others from companies that can be used to quantify this. Other MRI findings in AD are reduced blood flow, which makes sense. As you have atrophy, you expect less metabolism and less flow. And similarly, with FDG PET, which isn't used too much anymore, at least at our institution, but actually is quite good at assessing the metabolic changes in AD. Okay, so I want to start just by a little history and talking a little bit about the first drug that really brought attention to these disease-modifying therapies, and that's aducanumab. This basically is a monoclonal antibody derived from healthy aged cognitively normal donors, and it binded aggregated amyloid. It is infused every 4 weeks. So again, a very characteristic feature of these new medications is that they are infusions, and that brings with it a lot of important considerations. So one of the first exciting trials was just demonstrating how well this drug was at removing amyloid from the brain. So this is a florbetapir or amyloid PET scan in 4 different patients. And here you could see, based on the different doses, after 1 year, you could see essentially removal of the amyloid plaque from the cortical areas. And this, was accompanied in this small trial with cognitive improvement. Now, this led to a larger trial. In fact, it led to 2 larger trials, one called Emerge and one called Engage. And the primary endpoint was using this clinical dementia rating sum of boxes score, which ranges from 0 to 18. So you can see how you stage these, and you can see again how potentially subjective these questions might be. And then, just keep in mind when we talk about the effect of the drug, this is over an 18-point scale ranging from normal to severe dementia. In addition to looking at this primary endpoint, they also looked at the amount of amyloid PET in the brain. In some patients, they looked at the amount of tau as well as CSF biomarkers. So this study was stopped about 4 years ago when it was determined that they would miss its primary endpoints. And then aducanumab was actually dropped from Biogen's pipeline. So this was a real disappointment. There was, at the time of the futility analysis, one of the trials was trending positive, while another one was not. And then, eventually these patients were followed up to conclusion, and the slides I'll show you are the final cohort results. So, this was obviously a big deal. This was a very promising drug, and there was a lot of concern when this was stopped, not just for this drug, but also for the future of research into this area. And let's look at some of the data from that. So the first thing to see is that obviously the drug actually engaged with amyloid. So the gray bars here are the placebo, and then these colored bars are different dose levels, but just showing you that in both trials, they were able to show that there was significant decrease in amyloid using PET imaging. I think which was really compelling was this idea of looking at tau. And although these are very small numbers, as you can see in these graphs, there was some suggestion that patients with placebo tended to continue to aggregate tau in the brain, whereas patients on the drug tended to actually clear tau as well. So I think this was quite exciting. This is just an example of some of these tau scans. In case you haven't seen them yet, you may be seeing them in the future. But for example, in a placebo patient, this patient has uptake within the mesial temporal lobe and the lateral temporal lobe. And you can see on follow-up that increases a little bit. Whereas on the drug, you have a similar type appearance, and perhaps it's reduced over time. And since we know that tau is related to symptoms, this is obviously very encouraging. Now, looking at the actual primary outcome, which was cognition, you can see that the 2 trials demonstrated significant changes. So again, what this represents is the change from baseline in that clinical dementia ratio rating sum of boxes that I showed you. And so going higher means more cognitive impairment. And you can see in Emerge, you get kind of what you expect, where the drug actually improves this. So you are slowing the decline. And the slowing of the decline is actually quite small. It's about 30% over this period. So again, some people have said that looking at the range of that scale, is this actually clinically significant? But for the other trial, it did not. And in fact, that there was no difference between the placebo and the drug. And the question became, why would 2 trials designed in exactly the same way lead to these different results? I think it's useful to look at one of the distinguishing characteristics of the 2 trials, which was how many people were able to be on uninterrupted high-dose therapy. And if you looked at this data, you actually saw more similar results with the drug performing better. And this kind of secondary data was data that then Biogen went back to the FDA for potential clearance with. And, there was a lot of news about this. The FDA advisory panel basically almost unanimously disapproved of clearing this drug. And part of the reason for that was that, these were really secondary analyses. And so that made a lot of sense to many neurologists in the field. But it actually turns out that despite these things, as we know, the FDA went forward and approved the drug. And, so again, there was a very fierce debate about this drug. And one of the issues that Tammy mentioned was that, because of the controversy, this drug has essentially been discontinued from the pipeline. So you won't see people actually taking this. But I think this kind of was the first sign that, in fact, you could see these changes and understand the magnitude of them. And this was followed up by another drug, lecanemab, which is the drug that we're all talking about today. And this showed very similar changes in terms of worsening, so that you could see here the worsening is sort of in the other direction. So the placebo shows more worsening than the drug itself. And again, this was very consistent with the initially positive trial from aducanumab. And this drug did not really have a lot of the baggage, and this was the first drug fully approved by the FDA. And this is what we'll be talking about. So let's talk a little bit more now about the side effects, and particularly amyloid. So we've seen lots of images, beautiful images from Dr. Benzinga already, but we're going to be breaking this up into ARIA-E and ARIA-H, ARIA-E being represented by either edema of the parenchyma or effusion within the sulci, and ARIA-H being defined by, again, either microhemorrhages within the parenchyma or superficial siderosis in the sulci. Okay. So this has been known, and this has been a characteristic of almost all of the drugs that have removed amyloid. And I think that the amyloid imaging that was shown earlier, suggesting that regions of ARIA may be forming where ARIA is being removed, is kind of an explanation for why we see this across many, many different drugs. So just to take a look at some of this and to describe it a little bit more fully, we're looking for edema on T2 flare or sulcal flare abnormality. It can be variable in location. It can be multiple. Interestingly, as we'll discuss, it's usually asymptomatic, but symptoms can occur, and these symptoms can be very nonspecific. These are symptoms that many people get, whether they're on drugs or not, in this age group. So headache, confusion, gait disturbance, vomiting, and this seems to resolve over weeks when the drug is removed from the system. Flare may require months, actually, to resolve. Okay. I think we talked a little bit about the pathophysiology, so I think it's very important and useful to remember that what we're probably seeing here is the effects of removing amyloid from the brain, which comes with, some blood-brain barrier disruption, leading to the edema and effusion, and if that can actually leak from the blood vessels itself, the microhemorrhage pathology. Okay. So I want to go over the grading because I think that as radiologists, this is going to be the most important thing that we deal with. And again, just like Tammy, I feel that it's useful to enshrine these in your templates if you can, rather than try to remember what they are, especially if you don't see a lot of these cases. So for ARIA-E, mild is less than 5 centimeters in monofocal. Moderate is less than 5 centimeters, but multifocal, or measuring 5 to 10 centimeters in greatest dimension. And then severe is if it's greater than 10 centimeters for a single site. It doesn't really matter if it's monofocal or multifocal. Okay, so let's look at a few cases. This is a woman who came in. She was an ApoE4 homozygote, again, which is somewhat of a higher risk for ARIA. She had intermediate amyloid at baseline, and she was actually treated with aducanumab. And this was routine follow-up as part of the clinical trial. And you can see that if you look at this, you can find these abnormal areas of flare signal in this patient's brain. And the first thing you do when you see this, obviously, is you need to go back and look and see if this was there at baseline. And in fact, if you look at baseline, in fact, it wasn't there. But again, do note that as many of these patients have, she has significant amount of microhemorrhage or white matter disease, which is present. So again, very important to distinguish normal white matter changes from ARIA. Okay, so when we look at this, now we know these are new. And since we can see that these are multifocal, by definition, this is a moderate case, right? So this is not greater than 5 centimeters, so it's not moderate based on that. It's moderate because it's multifocal. Okay. I think one of the important things that we have to do as radiologists is to differentiate ARIA-E from other pathologies. And I think this is a quote from our esteemed moderator. In a patient on these drugs, a new region of flare hyperintensity is suspicious. And once it's suspected, you really do need to look at the full clinical picture because there are a lot of potential mimics out there. Okay, what are these mimics? The first one, obviously are white matter changes. And I think it's very challenging because older patients are going to have white matter changes at baseline, and they're going to have new white matter changes that occur over time. It's really quite expected. And so, I suggest trying to use a scale for this. And in many places, a lot of white matter disease will be a contraindication to putting patients on the therapy in the first place. I think a much harder diagnosis to exclude is PRESS. And there's some people who believe that ARIA-E is nothing more than actually PRESS in the setting of these drugs. Again, one of the things that may help you with this is, that PRESS frequently develops an association with cytotoxic medications, preeclampsia, sepsis, renal disease, and autoimmune disorders. So again, if we're going to be putting people with these kind of conditions on this drug, we're going to have a very hard time distinguishing PRESS from ARIA. But again, in the setting, I think it's very hard to say that something is PRESS and not ARIA. Another thing that you might worry about is subacute infarct, because infarcts can show up in very different ways. You can have things that are asymptomatic in older patients, as we know. We saw an example of that, and we've definitely seen examples of that at our institution. But again, this is where, having diffusion, having a follow-up available is very helpful. So again, we don't typically give contrast, of course, for the ARIA examinations, but if you did, often in subacute infarcts, you will see enhancement. Another potential artifact is from inhaled oxygen. Again, I think that this is something you may see in inpatients, not so much in our asymptomatic outpatients, but we know that the paramagnetic effects of oxygen can lead to high signal within the sulci on flare. So to avoid this, you really do need the history to understand this. One thing I would also say is a pitfall is the presence of CSF flow artifact. And, as you can see here, this is an incredibly old study. We've been doing this for a long time. There's quite a big advantage to doing 3D sequences that can null out the CSF flow artifact and help you avoid overcalling ARIA-E within the sulci. Interestingly, some of the software vendors that are developing tools to detect ARIA have typically been trained on 2D flare because this is what has been in clinical trials and may not work as well with 3D flare. But I think long-term, if you're reading these cases, it's useful to do 3D flare. And in fact, at our institution, we do both just because sometimes one is ambiguous and the other is much more clear. So again, speaking to the importance of high-quality imaging and attention to detail. But I would say if you're only going to do one, I would recommend a 3D flare. Okay, let's talk a little bit about ARIA-H. This is, again, basically small punctate, usually much smaller than 1 centimeter lesions that we see on GRE imaging. And I want to be clear that all of the information we have from trials has been using GRE imaging, and we'll talk about the role of SWI. The other finding is siderosis, which is low signal seen in a sulcus. And again, these are very characteristic findings in cerebral amyloid angiopathy, which is a disease we're all quite familiar with and very comfortable with diagnosing. It's important to remember it may be separate or overlapping with ARIA-E. Okay, so let's talk about a grading scale here. And here we have to split up the grading scale into two different areas. One is based on microhemorrhages, which is just based on counting. And this sounds like a very simple scale, but I will tell you that being able to identify what was present before, what is new, with all of the challenges of imaging these very small objects, it's not very simple, but this is still the system that we do have. And then superficial siderosis, where you're really looking at mild, moderate, and severe just based on the number of sulci that are involved. 1 for mild, 2 for moderate, and greater than 2 for severe. Okay, so let's go back and look at another case. This is a patient who I showed you before. Again, you can see a microhemorrhage here in the occipital lobe after the 3rd dose. Now, of course, it's important to go back to the original study, and you can see that pre-treatment, in fact, that is actually there. So this would not be considered ARIA-H based on this. Now, however, you can see that there are areas of new microhemorrhage that were not present. So in this case, there were less than 5 microhemorrhages. Whoops. And for this reason, this is a case of mild ARIA-H. I think the biggest differential diagnosis here is cerebral amyloid angiopathy related inflammation. Again, just like PRESS, I think it's very difficult to distinguish these, what's been due to drug and what's due to other factors. So again, if a patient is on these therapies and you see something that looks like this, you have to be very concerned that you're dealing with ARIA-H. Okay, so we've talked about what it looks like. How often should you expect to see it? Well, it turns out that it has depended on the different drugs over time. And again, these are all clinical trials. So, once something gets used in a more widespread way, we may see very different numbers. But you could see here for lecanemab at the bottom, they had an incidence of about 10% greater than placebo for ARIA-E and about 6% for ARIA-H. Okay. Again, important to think about the risk factors. Increased dose obviously is a risk factor for ARIA. The presence of the ApoE4 allele. It turns out if you have greater than 4 microhemorrhages at baseline, you're at higher risk. And in our center, we don't treat these patients typically, or severe white matter disease at baseline. The time course, you should expect to see it in the first sets of infusions. So this is why the timing exists that I'll talk about in a few minutes. And then in terms of severity, it is remarkable that this is frequently asymptomatic because the brain imaging is often quite impressive. Again, mild ARIA tends to be more common compared to moderate or severe. And it's important to realize that ARIA-E is almost always transient and goes away with removal of the drug. ARIA-H almost always stabilizes again. Okay, so what are the imaging schedules that you're going to be thinking about? I think it's very important to have a baseline MRI. And again, if it's not in your center and you expect the patient is going to follow up in your center, you may very well want to arrange for a baseline study because everything you do is going to be dependent on what they look like at baseline. The trials used baseline MRI up to 1 year prior to therapy. I think that it should probably be shorter because, if you have interval changes in between, you run the risk of saying that they're related to the drug when they weren't. So, as close as possible to the start of treatment is ideal. For monitoring, the package insert will say that you need to do this before the 5th, 7th, and 14th infusions, and what that translates for lecanemab, which is a 2-week infusion drug, at about the 3-month level, the 4-month level, and the 7-month level. Some sites we've found may actually want to do more. Important to remember that if you have symptoms in these patients, you don't wait to do a monitoring MRI. This is something that, you either come into the ED or you get as an urgent outpatient, but it's anytime and it's off schedule. And finally, as we mentioned, once you find ARIA, if you do find ARIA, you do need to follow it up. And so recommendations are to do this on the scale of about once a month, once every 2 months until it resolves or stabilizes. Okay. Just want to emphasize that just because you've had ARIA once, it doesn't mean you can't have it again. This is a case of a patient who was had 6 different episodes of ARIA, both ARIA-E and ARIA-H. And the remarkable thing is, throughout this whole period, they were asymptomatic throughout. And in fact, this was a trial patient, and they actually had to go off the drug, even though they never had any clinical symptoms. Okay, let's talk about software. Maybe software will help us in this task to some extent. I'm just showing some initial experience that we've had with the software. And so the idea is that, this software receives a baseline study as well as a follow-up study. The baseline study here is on the left, and then tries to both identify new flare changes. So here it's identifying 2 areas in the brain that are new from the prior, and then applying the ARIA grading system to grade this as moderate. So I think this will be evolving over time. I think it's actually quite challenging. And, one example of the challenge here is for another patient who was evaluated for ARIA-H. And you can see here that this was graded as mild ARIA-H for this new microhemorrhage. But you can see that if you actually identify where it is, you can see that that's actually probably just a typical vessel along the falx. So again, I think these things will evolve with time. I think they may be helpful to us as radiologists, and I think that Dr. Francesca will show some cases as well. Okay, so what do you do with this? Why is this important? Why it's important is because it really drives treatment. So I'm going to just focus on asymptomatic clinical severity and just point out that if you have mild disease, in theory, you are recommended to continue dosing at the current dose and schedule and not change anything. Now, if you have moderate disease or severe ARIA-E or moderate ARIA-H, the idea is typically to suspend dosing, and then once imaging findings resolve, you can resume the dose. If you have severe ARIA-H, usually the recommendation, as you can see here, is just to discontinue completely. So again, this is still something that is, not totally standardized and very much on a case-by-case basis, but it's good to know what these kinds of diagnoses mean to the patient and their therapy. Okay, so I want to finish up just talking about some of the considerations when you're thinking about doing baseline and follow-up MRI. The first is you really should try to use a scanner that can be kept consistent for the future, particularly regarding field strength. And the reason for this is because 3T is more sensitive for microhemorrhages. So that if you have 3T and 1.5 available, you may want to consider using 3T for the baseline study, because otherwise you may have a risk of calling a new microhemorrhage, which is not new, just something that was not visible on the 1.5T study. You should standardize your sequences, and I'll talk a little bit about this. If you do 2D or 3D sequences, I would stick with them. I would consider using both if you have time. These tend to be fairly short protocols. Again, the question about whether using GRE or SWI will be more sensitive. But again, we don't really know how important it is to be very sensitive. But I think it can be very helpful to resolve cases that are ambiguous on GRE. And finally, of course, it's very important to report the number of microhemorrhages and the severity of white matter hyperintensities, and to document, because you're doing a favor to yourself if you document where these things are, because it will turn out to be very difficult to know what you were thinking, 3 or 4 months later. For follow-up, again, use the same scanner if possible. If not, use the same field strength. Keep 2D versus 3D imaging consistent. Avoid switching back and forth between GRE and SWI, and always report microhemorrhages on GRE. Obviously, any new abnormalities need to be clearly documented, and at least we find it important to communicate directly with the treating physicians, because often these scans are very close to the next infusion. So it's important to reach the patient before then. And please remember to use the classification system that we described. So ASNR has recommended some protocols for ARIA imaging, and I just want to share some of those with you here. They felt that 1.5 or 3T both were sufficient, but again, remember, this is probably not something you can do at ultra low field, although I know Dr. Benzinga is doing a trial looking at ultra low field in this setting. I think one of the great challenges will be to identify microhemorrhages at extremely low field. So again, you probably want to use standard high field scanners. You want to use either 2D or 3D flare. As I said, I prefer to have both just to remove ambiguity, because both can have artifacts. You definitely need to do 2D T2 star gradient echo. And as mentioned before, diffusion can be helpful if patients patients have asymptomatic ischemia, which they will have, just to make sure you're not calling that ARIA. If you're looking for a protocol, you can look actually at the ASNR website, and there are standardized protocols from each of the vendors that you can use. Now, other types of sequences you might consider are high-resolution T1 weighted imaging, which may be helpful to evaluate atrophy changes over time, and SWI. And then lastly, please remember that no contrast is needed for ARIA evaluation. We really don't want to be giving contrast for these cases. It's not useful, and it can potentially lead to complications. Okay, I want to finish up just talking a little bit about the severe outcomes. This is an example of a patient who was treated with lecanemab, came in with stroke-like symptoms, and then received intravenous TPA. And as you can see here, obviously hemorrhage is a risk factor of getting TPA even in the absence of lecanemab. However, the amount and severity of this was very atypical. And the thought was this is probably related. So, again, these older patients are going to come in with stroke-like symptoms. So we have to be very careful and think about, what are the risks and benefits of current stroke treatments. I think this is going to be very challenging, as mentioned before. We've definitely already seen in the number of patients that we've had, some of them have come to the hospital and it's not been, totally communicated that they're on these drugs necessarily. So, we do really need to think about how do we educate the emergency department? Do we need something more than just, some note in the chart? Do patients need to have bracelets, et cetera? And then there needs to be tech education because, again, typically for these kinds of symptoms in most hospitals, patients will get CT. And CT is really suboptimal for identifying, especially the mild and moderate forms of ARIA. So, if a tech sees this situation, maybe they can help guide the team towards getting the appropriate MRI. Okay. The last thing I want to talk about is donanemab. And donanemab is another monoclonal antibody, but it's a little bit different in that it's thought to target just amyloid beta present in brain amyloid plaques. And one of the important things here is that the trial had two interesting features. One was that to get into the trial, you had to have tau pathology, which it raises kind of the level of confidence, I think, in the diagnosis. And then they were monitored with amyloid PET, and if you could show that the amyloid had been removed, treatment was stopped. So this is quite desirable because currently with lecanemab, there are no real guidelines for stopping. And what they showed in this Trailblazer ALTS trial was that there was, again, a very similar, about 30% slowing in the cognitive impairment over time. And that if you actually, this is the 30% shown here, but that a lot of people could actually get off of this drug because you could show that the amyloid had reduced significantly. So this has still not yet been FDA approved, but I think this is coming, and I think it's good to be aware of it and to start thinking about maybe in your centers, do you need capacity to do tau imaging of some kind? Okay, what does it all mean? It means that patients can get treated. The guidelines really are for MCI and mild AD. We need proof of amyloid positivity. We need a baseline MRI within 1 year. We need asymptomatic screening MRIs as shown here, and then clinical evaluation and MRI if symptoms are present. In the future, we may also need tau PET or some other method to assess tau and follow-up amyloid scans. So in summary, AD, a previously incurable disease, now has multiple disease-modifying therapies. Imaging is playing a key role to identify the appropriate patients, but also to monitor safety. And ARIA is a side effect that has to be monitored with MRI, and you're going to see a lot more MRI if you start prescribing this drug. Usually it's going to be asymptomatic or mild. However, it's important to know catastrophic events have been observed. Be aware of the potential mimics, and please, if you can, try to standardize both the imaging you do and the reporting that you share to be very clear with your recommendations. And with that, thank you very much.
Great. Wonderful, Greg. Thanks so much for that talk. And just for the audience, we are going to hold questions until the Q&A session at the end. I really enjoyed Greg's talk. I think he had a lot of great pearls and pitfalls. And, many of you may have noticed this, that, the symptoms, the findings of ARIA seem pretty straightforward when you read about it and when you see bread and butter cases, but as he mentioned and showed, there are many mimics that can be confusing. Also, imaging is dynamic. It's not static. The field is changing and field strengths are changing. And so as we move into low field strength, happy to hear that Dr. Benzinga is doing a trial to see how ARIA will manifest on low field strength scanners, because we don't really know. And that's even true of, it's not 100% clear what to expect when we move to 2D to 3D flare and gradient to susceptibility weighted imaging for susceptibility artifact and hemorrhage. So still a lot of still a lot of pitfalls, a lot that we have to learn to manage these consequences of monoclonal antibodies. And with that, I want to introduce my my good friend and colleague, Anna Francesca. She's associate professor at Lenox Hill Hospital, Northwell Health System. She's part of our ALZNet group, as Dr. Jordan mentioned. She's also a member of ACR Commission on Neuroradiology and chair of the Commission's Dementia Working Group. And she'll be reviewing a spectrum of ARIA cases. So I'll turn it over to Dr. Francesca.
Thank you so much, Chris, for the warm introduction. I'm really excited to be here with everyone tonight and, to follow Dr. Benzinga's and Dr. Hartsock's excellent talks. I'll be reviewing a variety of ARIA cases, and at the end, I will go a little bit more into detail on the various AI tools that are currently in development for ARIA detection, and also the current state of practice across the United States. So these are my disclosures and my grant funding information. Now, I know that both Tammy and Greg, went through the grading scale, but again, since ARIA is inherently a radiologic diagnosis, I feel like it doesn't hurt to repeat this one more time through a few examples. So now for ARIA E, we call mild ARIA E, as you see on this example on the left side, when we identify flare hyperintensities that are less than 5 centimeters in maximum diameter. Moderate ARIA E, as seen here in the center, is when we have a single site measuring 5 to 10 centimeters, or more than one site, with each site measuring less than 10 centimeters. And then finally, severe ARIA E, as you can see here on the right side, is if we have flare hyperintensity measuring greater than 10 centimeters in one or more separate sites. As far as ARIA H, and specifically microhemorrhages, mild ARIA H is the interval development of 1 to 4 new microhemorrhages, as you can see here on the example on the left. Moderate ARIA H is identifying 5 to 9 new microhemorrhages, as you can see here in the middle. And then severe ARIA H is 10 or more new microhemorrhages. And finally, as far as ARIA H superficial siderosis, mild is when we identify one new focal area of superficial siderosis, as on the example on the left. Moderate is 2 focal areas of superficial siderosis, and severe is more than 2 focal areas of superficial siderosis. So with that, we can take a look at our first case. This was a case of mild ARIA E and moderate ARIA H, which had both microhemorrhages and superficial siderosis. This patient, when they presented, was asymptomatic. This was detected on a monitoring scan, and his infusion therapies were stopped due to the development of siderosis. So here we have examples of the patient's T2 GRE in the top at 16 weeks, and then the follow-up scan where the abnormalities developed at 25 weeks. And we can see that they developed 5 microhemorrhages, at least 5 microhemorrhages, I should say, in the region of the left insula, also in the right parietal lobe. And then there was interval development also of 2 areas of superficial siderosis in the left frontal lobe and in the right occipital region. Now this was the 2T flare for the same patient. On the left is the baseline scan. In the middle is the 16-week surveillance scan, and then on the right-hand side, the 25-week scan. And you can see in the middle at 16 weeks development of a single area of flare hypertensive signal abnormality in the left occipital region, and this was classified as mild ARIA-E. And I'm just going to scroll through the GREs a little bit just to get a sense of for the distribution of the superficial siderosis and then the microhemorrhages as well. Okay, so the second case had mild ARIA-E. This patient presented with complex partial status epilepticus in the ER, and even after 5 months, it was unclear why the patient was not returning back to their baseline function. It wasn't clear if this was due to disease progression, persistence effects of ARIA, although again, the residual ARIA, as you will see, was minimal. So here we have on the left the initial T2 flare, the 3-month scan when symptoms developed, and then the 8-month follow-up scan. And you can see that at 3 months, there was interval development of prominent flare hyperintensity in the left occipital lobe, which by 8 months had nearly completely resolved. Here are just a couple of slices of that same patient, so you have a sense of the extent of the abnormality. And again, even though radiographically by 8 months, these findings were improved, clinically, the patient was not doing well. Our next case is an example of moderate ARIA-E. The onset was at 48 weeks. DWI images were negative, excluding an acute infarct. This patient was asymptomatic, but they went on to develop recurrent ARIA-E each time the monoclonal antibody therapies were restarted. So you can see here the baseline flare on the left, and then in the middle, the flare at 48 weeks, and then the corresponding ADC maps just to exclude the possibility of cytotoxic edema, and the DWIs were consistently negative. And you can see that the patient at 48 weeks has new flare abnormalities in the left occipital and also in the right frontal lobe. And given the 2 separate locations, this was classified as moderate ARIA-E. And I'll just scroll through a couple of slices of this patient of the baseline MRI versus the 48-week scan. And you can see nicely highlighted here by the arrow the development of interval ARIA-E. And here I have the ADC images also just for comparison to highlight that there was no suggestion of cytotoxic edema. And then this patient also ended up developing a moderate ARIA-H. These are GRE sequences. On the left, you have the baseline scan, and you can see a development of several microhemorrhages, more than 5 in bilateral temporal lobes. And here and also in the right frontal lobe. And here we are. Okay, so the next case is an example of severe ARIA-E. This patient was admitted to the ICU. They were initially presented with loss of consciousness or decreased consciousness, I should say, problems swallowing and eating, and in fact went on after a 2-month hospital stay to a complete recovery. So here's an example of this patient of the T2 flare. And again, you can see that there are multiple areas in the bilateral cerebral hemispheres, and they did measure greater than 10 centimeters. I'll scroll through a few images just so you get a sense for the severity of these findings. And again, this patient ended up having a complete recovery. So here's another case. This was a case of moderate ARIA-E that was detected on the 4 weeks of the 1-month monitoring scan. This patient was asymptomatic, and there were 7 separate regions of new ARIA-E. I'm just going to scroll through the images just so you get a sense of how relatively subtle these findings can be. So on the left, you have the baseline scan, and on the right-hand side, the 4-week scan. And again, this patient was completely asymptomatic. So I have the findings here circled within the green circles, so you can get a sense of how relatively subtle this can look. All right, so the next case was an example of mild ARIA-E with severe ARIA-H. And interestingly, the patient's ARIA-E continued to progress, even though the infusions were halted. So the first follow-up MRI after halting the infusions at 1 month after stopping therapy, the ARIA-E actually was more extensive. And then also at the initial scan, when ARIA-E was detected, there were no new microhemorrhages. And then on the 1 month monitoring scan after discontinuation of therapy, the patient went on to develop about 20 microhemorrhages. And in this case, DWI imaging was also negative. So I'm just gonna scroll through the current scan, and you can see here the ARIA-E. You can see the corresponding ADC maps confirming that there was no cytotoxic edema. And then these are the numerous microhemorrhages that ended up developing in this same region. And finally, just an example of contraindications to starting therapy. This is an example of a patient who came in for their baseline MRI and had about 40 microhemorrhages on the baseline GRE sequence that precluded therapy. So just to refresh, antithrombotic medications are associated with increased risk of ARIA-H, but really the main risk factor is basically having microhemorrhages at initial baseline scan. So patients with prior microhemorrhages have an increased risk of developing future microhemorrhages, and 5 or more microhemorrhages or any area of superficial siderosis is considered to be an exclusion criterion for monoclonal antibody therapy. And here is just an example of that baseline GRE sequence. And finally, I'd like to show you a case that was given to me by Dr. Napoli. And this is an example of the utility of AI tools for ARIA detection. And I'll go a little bit into greater depth about them once we wrap up this case. So, in terms of AI tools for detection ARIA, there are a couple of companies developing these tools, including our sponsor Echometrics, also Cortex, the producers of NeuroQuant. And the idea is that these automated quantitative softwares will provide us with the location and count of new microhemorrhages and superficial siderosis for monitoring ARIA-H, that they will measure volumes of edema and sulcal effusions for detecting ARIA-E, and then also plot longitudinal graphs across serial prior MRIs to really reflect these dynamic changes over time. And then, of course, display criteria for grading severity. Here's an example of Echometrics' product. On the left-hand side is the ARIA-E report. On the right-hand side, you see the ARIA-H. And again, they give you sites of involvement for ARIA-E. They grade severity, and they give you the change in volume. Meanwhile, for ARIA-H, they give you the count of interval microhemorrhages and or superficial siderosis and evaluate severity. Similarly, this is Cortex's example, kind of along similar lines. They have tools for both ARIA-E and ARIA-H detection. And again, one key thing that Greg already mentioned in his talks, the majority of these tools and development were trained on 2D FLAIR, so not on 3D sequences, which are commonly used in clinical practice, especially at academic centers, and also solely on GRE and not an SWI sequence. So we have yet to see how helpful they will be in real life practice. And currently the product that Echometrics developed is undergoing FDA review. So there's an interesting article that came out in JAMA earlier this year. They looked at unassisted versus AI-assisted reads for ARIA, and approximately 30% of both ARIA-E and ARIA-H cases were missed. These unassisted reads were both by radiology trainees, but also by subspecialty neuroradiologists and people that had experience in ARIA reads. And of course, the majority of these misses were in mild cases. Over 50% of mild ARIA-E and about 40% of mild ARIA-H's were missed, but at the same time, about 15% of moderate to severe ARIA was missed as well. And with the AI tools, radiologist detection performance improved, and as one might expect, this was particularly helpful in the detection of mild ARIA. And just to highlight how these, tools work, typically, you have the input 2D flare and GRE sequence. The software looks at both the baseline and the follow-up scan, registers the time point, and then performs segmentation for both ARIA-E and for ARIA-H. Then the output, of course, is the annotated images with these summary reports. So we can take a look at a case that was processed with the help of one of these tools. This was a 66-year-old female who presented with an initial MMSE score of 26, and she was an APOE4 allele homozygote. CSF biomarkers were positive for both amyloid and tau, and at that point, the patient was presented with the option of starting under Duhelm, but reimbursement was not available. And also the initial MRI was not processed with any kind of volumetric software, but then in retrospect, when it was processed, the software did demonstrate temporal parietal atrophy with marked volume loss in the bilateral hippocampi. So about 6 months later, the patient was getting worse. Her MMSE dropped to 22. And at that point, the patient was enrolled in a free access drug program, and aducanumab was started. The patient had 8 infusions, and the initial MRI was relatively poor quality, and segmentation was not successful. So the patient was doing well for the first 6 months of treatment, and then presented with new onset occipital headaches and visual issues. And at that time, an MRI was obtained. The MRI report, or the radiologist unassisted read, described ARIA-E in the parieto-occipital regions bilaterally. Typically ARIA-E is most common in the posterior regions, so the parieto-occipital lobes, similar to PRESS, as Greg mentioned. And they did not notice any areas of ARIA-H. Once the MRIs was put through the AI tools, there were actually 2 new microhemorrhages as well. On the follow-up scan, about a month later, the occipital ARIA-E was resolving and improving, but the patient developed new left frontal ARIA-E, and again, no new ARIA-H was noted by the radiologist, although subsequently there was an additional new area of microhemorrhage, again, mild ARIA-H. And finally, the last scan was in April of that same year. ARIA was almost completely resolved, and the ARIA-E and the ARIA-H had stabilized. At that point, the patient was clinically asymptomatic, and after further discussion with the family, and despite the APOE4 genotype and history of ARIA, decision was made to resume therapy. And a patient continued to be asymptomatic with no ARIA and a stable MMSE. So with that, just to close, I'd like to briefly go over the initial clinical experience in the US, with the caveat that while patient numbers are rapidly increasing, this data will present kind of cutoffs at mid-January of this year. And some key points that we have to take home is that uptake at first was quite slow, but it is speeding up. By mid-January, there was about 3,000 people across the country on Leqembi, and as you'll find out later on, there was over 10,000 people on Leqembi by the end of March. Initially, most people are getting treated at academic centers that have clinical trial experience with monoclonal antibodies. But the demand for the drug is rapidly accelerating and will soon outstrip the capacity of specialized dementia clinics. And as you can see, these are actually numbers from Dr. Benzinga's institution from WashU. As she mentioned, there's over 170 patients on the drug now. They're the busiest site in the US, but when this data was reported, there was about 70 patients on the drug. And just to highlight a few things, there was 4 people that had to stop treatment. 2 of these stopped treatment due to ARIA, and 2 stopped for reasons unrelated to the drug. And finally, across the US, about 60% of large healthcare systems have approved Leqembi use as of November. As I mentioned, the number surpassed 10,000 by the end of March. And here's a list of several academic institutions that were among the first to start treatment. And finally, just a word of caution. This is an image, a histochemistry image from that same case from Nature Communications that Dr. Benzinga showed at the start of the talk. And you can see here, this is a patient who died from ARIA and was on Leqembi. And you can see the blood vessels in the meninges are full of amyloid with multiple aneurysms developed. So again, just to highlight that these drugs do have serious side effects, and really radiologists are the ones that typically are the first to detect and diagnose these, and really accurate reporting, standardized reporting, and prompt diagnosis are crucial to making sure that as many patients are treated as safely as possible. So that's all I had for today. Thank you so much for your attention.
Thank you so much, Anna. That was superb. And unfortunately, we're getting close to the end of our session, but I do think we have time for a couple of questions. Let me go to the audience chat. So one question is, what about the vessel wall imaging in ARIA? I believe it can have a big role in predicting future strokes and activity of disease post-treatment. Any of you care to comment on that? Greg,
Greg.
you're muted. You're muted.
Oh, sorry. I'm happy to mention a little bit about that. I mean, I think there's a big role for looking at our advanced imaging. A lot of this has not been done in the clinical trials. And I think that one of the reasons to have a very streamlined ARIA protocol is to explore some of these other things. But, until we have data on large numbers of people, it's going to be hard to know. I can definitely see the potential value of looking at the vessel wall, given the symptoms and these autopsy images. So, these are things that I think the ACR can take the lead on, and maybe even try to organize into registries such as the AlzNet registry that Dr. Jordan is leading. There are a lot of unknowns, especially around advanced imaging. And I think there's plenty of potential to help us understand better, particularly who is at risk of catastrophic outcomes.
Great, thanks, Greg. Jerry, were you going to?
No, Greg was spot on. That's beautiful.
Okay, great. There's another question. Do areas of ARIA on MRI correspond to areas of higher amyloid burden on PET?
Well, I can take that one. As far as amyloid PET, the volumes have really increased astronomically in clinical practice. At Northwell, we scan about 80 amyloid PETs a month. Considering before Leqembi was on the market, we were scanning maybe a handful a year. So the volumes are certainly extremely high, but at this point, in the clinical setting, typically patients get an amyloid PET at initiation of treatment, and we have yet to see if they will actually be obtained to monitor treatment response, or even, as Greg highlighted, the donanemab Trailblazers trial to potentially determine when patients should be off these drugs. So really, the idea of monitoring ARIA through amyloid PET, that has not been assessed as of yet. And
Right.
typically also just to say that, you know, in terms of accumulation of amyloid, these scans are relatively binary. They're either negative or positive. And when we have a positive scan, what we identify typically is diffuse accumulation of the tracer throughout the neocortex without specific brain regions being distinctly involved or not involved.
Great, thanks, Anna. And then the last question, this is for you, Greg. What's the mechanism of tau clearance treated with lecanemab? And did you explore any brain oxygen saturation in the individual with ARIA?
It sounds like those might be two different questions. You know, I think that in terms of the mechanism for tau being reduced, you know, again, you wouldn't be surprised perhaps if tau either stabilized or didn't go up. It's a little surprising that tau is also being removed, but I don't think it's very clear what the mechanism is there, unless it's also being mobilized somehow. I don't think we know much about this. I think this is, again, points to the very high value of advanced imaging in these patients, especially if you can do, you know, standardized imaging in a significant number of patients. And we have these wonderful tools. And I think that one of the really big roles of tau is going to be to see, you know, can we use tau more as a biomarker of patients that are going to get benefit? I think, you know, neurological exams are notoriously difficult to perform. They're very subjective. People may be just having a bad day, for example. So, you know, if we could quantify that with tau imaging, I think that that could be very valuable. But it just points to the fact of how early we are really in this whole journey, I would say, with these new medications. There's lots to learn. There's lots of opportunities for imaging professionals to have a big impact.
Terrific.
And I can piggyback on the tau comments just to say that, you know, tau is slowly entering clinical practice. We recently had one of the first clinical tau PETs in New York State. And just to highlight that while that case that we had a couple of months ago was an out-of-pocket patient, we are actually currently in correspondence with the CMS and with the Society of Nuclear Medicine and Molecular Imaging, because tau with fluorotaucipir actually does have pass-through status. So it seems like if our local MAC will be on board, we can actually start offering it widely clinically and have it reimbursed for Medicare patients.
Terrific. Okay, well, we're at the end of our session here, and too bad time goes by when you're having fun, right? As they say. But we want to thank our esteemed speakers. I want to thank my co-moderators, all of you for your outstanding contributions, and the ACR staff for their expertise in supporting this program. We thank all of you for attending, and the session will be available in the Enduring Learning materials. And to everyone, we bid you farewell. Until next time, take care.